Dr. Brady has over 25 years of clinical experience. He's a licensed naturopath in Connecticut and Vermont, as well as a board-certified clinical nutritionist. He's the vice provost and an associate professor of clinical sciences at the University of Bridgeport. He also has a private practice in Connecticut and recently released The Fibro Fix, an awesome book about fibromyalgia, and he was the host of the Worldwide Summit of Fibromyalgia, the Fibro Fix Summit. So welcome, Dr. Brady.
Hey, Amy, thanks. It's great to be with you again, and appreciate you having me on.
I'm delighted to have you back talking about the association between fibromyalgia and thyroid.
Right, absolutely.
So let's just dive into it. I mean, in your clinical experience, I see a lot of people that, have fibromyalgia, but really it's thyroid or thyroid and fibromyalgia. Can you kind of just tell us in your experience about the similarities between the two and also maybe why people get one diagnosis or the other?
Yeah, well, in the book, The Fibro Fix, and also in the summit, I went into great detail and I talked to a lot of people about, this whole problem of misdiagnosis in fibromyalgia. And the studies actually show, the largest study that was ever done, actually using the American College of Rheumatology criteria for fibromyalgia, showed that when family physicians and even rheumatologists rendered a diagnosis of fibromyalgia, if those people were then sent to a panel of experts on fibromyalgia who really know as much as anyone else could possibly know, they found out that the diagnosis was only correct about 33% of the time. So if you turn that around, it means 2/3 of the people were misdiagnosed. So, and I think that sometimes the numbers are even worse than that. And it just simply comes down to a couple of things. One is, I don't think medical doctors, medical providers, healthcare providers of all types are trained very much about fibromyalgia, about what it really is in a very serious, comprehensive way. They don't take the time to rule everything out first, like they're supposed to, according to the diagnostic criteria. And they don't think of all the other things that could cause the same kind of symptoms, or at least a large number of those symptoms, particularly disorders that might be in combination, like maybe one disorder doesn't get you all the symptoms that would be associated with fibromyalgia, but if you have 2 or 3 disorders all at once that are not fibromyalgia, if you look at the symptoms in their totality, it might look like it, particularly if the patient happens to be a woman, and particularly if she happens to be be anywhere between 35 and let's say 60, right? The prime age of the fibromyalgic patient. So there's a lot of disorders that masquerade as fibromyalgia, and there's the top 3 masqueraders that I talk about in the book. And one of those top 3 masqueraders, or disorders that will get someone a diagnosis of fibromyalgia when they really don't have it, they have something else, is underappreciated or previously undiagnosed thyroid disorders, hypothyroidism mainly, okay? Because when you look at the symptom profile, it includes fatigue. It includes, cognitive dysfunction or not being able to think clearly, which can be interpreted as so-called fibrofog, right?
Yeah.
And then those patients often can be achy. They can have pain in the muscles, pain in the soft tissues, pain in the joints even, which can be misinterpreted as fibromyalgia. So if you have a middle-aged woman, she's complaining of fatigue, pain, she's complaining of sort of vague gut problems, like that would be probably labeled by doctors as IBS, slow peristalsis, right? Slow gut function. That can be caused by hypothyroid as well. So if you're just looking at thyroid disorders from the very conventional paradigm and looking at very limited tests and having to have it be entirely, extremely abnormal to be diagnosed, you don't queue up to the fact that it actually might be something as relatively simple compared to classic fibromyalgia, that is, as a thyroid disorder.
Right. And I guess kind of backing up a little bit for those that don't know or might be new or that are maybe getting this misdiagnosis, why don't you go through and tell us, what criteria do need to be there in order to have a diagnosis?
Of fibromyalgia?
Mm-hmm.
Well, the current diagnostic criteria, gold standard, is the American College of Rheumatology's diagnostic criteria, which was reissued in 2010 and then modified slightly in 2011. But The first thing, and it clearly states this, and this is where a lot of docs miss it, is that it's a diagnosis of exclusion, which means you have to rule out every other possibility that might be causing the symptoms before you render a diagnosis of fibromyalgia. And one of the confounding issues also is that there's no objective laboratory test for fibromyalgia. There's no fibromyalgia factor on a lab form that you can check off and have the lab tell you yes or no, they have it or they don't. So you have to use a lot of labs, and you have to do differential diagnosis. You have to basically rule out other medical conditions that can cause the problem. But then, we're functional medicine physicians, right? So we get deeper into the weeds on people's metabolism and how it's functioning, how they're making energy, and a lot of other things about their biochemistry that the conventional doc would never even go there. So we tend to rule out the overt medical diseases, but then we also have to rule out the metabolic stuff that can be causing someone to have these symptoms before we would render a diagnosis of fibromyalgia. But there are other things that simply have to be present, and I don't think health providers make sure that they are before they render the diagnosis. One is the patient has to perceive achiness or pain all over the body. It cannot be regional. It can't be in one or two places. It can't be confined to your neck or your low back, or even the neck and the low back or the pelvis. It literally has to be a hyperperception to pain and an achiness that is pervasive around the body, above the waist, below the waist, left side, right side, along the midline, out at the extremities. It's everywhere, because in true or classic fibromyalgia, the problem actually is not out in the body. It's not in the muscles. It's not in the soft tissues. You just perceive achiness there. The dysfunction is actually deep within the brain and the central nervous system. So since it's a problem centrally, it doesn't discriminate on which part of the body that you feel achiness. You feel it everywhere. So part of the clinician's job is to ask the patient subjectively, where do they feel that their pain is? And if they tell me, oh, it's down here and it's up here, but it's not everywhere, I'm not thinking it's actually classic fibromyalgia. If they tell me it's in the joints, I'm not thinking it's fibromyalgia, because it's not an articular or a joint problem. It's a perception of pain in the soft tissues throughout the body. So they have to perceive it everywhere. And they generally also have profound fatigue. They don't have much energy. And a lot of that is because they don't sleep well. They have unrefreshed sleep. So they may sleep 14 hours a day trying to, get rejuvenated, but they never do. They have what's called unrefreshed sleep. And we can talk about that more if you want, what that specific sleep dysfunction is. But it's a very well-defined, very specific type of sleep dysfunction. But they don't sleep through all the stages of sleep. They don't get rejuvenated. They don't get restored. Therefore, they're always fatigued. They're always achy. But almost 100% of them also have intestinal issues, which we would probably label irritable bowel syndrome or IBS. So they have a lot of bloating, cramping, gas, can have constipation frequently. Some have diarrhea. Some have alteration of their bowel movements between constipation and diarrhea. But the final linchpin is that the vast majority of the true fibromyalgics have some level of mood disorder. Usually it's mild depression, mild to moderate depression, but they often have anxiety, sometimes to the point of having occasional panic attacks, many times not, but they're very anxious. Their nervous system is sort of stuck in a mode where they're waiting for the next shoe to drop, right? They're always in like, what's coming at me next kind of mentality deep in their nervous system. And it's subconscious. It's not them making that decision to be like that. It's just the way their nervous system is. And it tends to be like that, often related to previous trauma, previous stress, and in the classic case, previous even abuse. So physical abuse, verbal abuse, mental abuse, sexual abuse. And particularly in women, if it happened early in life, like during early childhood, if there was a situation going on in their life where they fundamentally felt unsafe or even threatened, particularly if they felt unsafe or threatened by someone who should have been protecting them, right? Like a family member, let's say, who, if there was an abuse situation, if that happens during the developmental period of the nervous system, it actually changes the way the brain deals with its environment. And you're always in sort of a defensive stance, if you will. And it can actually change the limbic system and the stress response system and get you stuck in a pattern that later in life ends you up in this place that we would call medically now fibromyalgia and irritable bowel syndrome.
Yeah, it's so fascinating. I mean, as I'm thinking back to some of my fibromyalgia patients, most of them do have, a history of abuse.
Right.
I think you and I were talking on your summit, the Fibro Fix Summit, that when I was an ER doctor and I used to go into a room of a patient who was diagnosed with fibromyalgia and genuinely in pain, but because I didn't understand it, and of course they give you no training in emergency medicine about how to manage fibromyalgia.
No.
I would just go in and of course everybody was thinking they were drug seeking and just wanting their Percocet, and then and I would just be so overwhelmed because I would have nothing to offer them other than pain medicine, sleeping pills, antidepressants.
Right.
And then coming into functional medicine, they're some of my most favorite patients because they have been so shunned by conventional medicine and just really been given the raw end of the deal because that's all that conventional medicine has to offer them. And then once they find functional medicine and they're listening to them and have tools to help them, they're some of my most favorite patients because they're so dedicated to getting well. And so I guess being that what are some of the underlying causes? We've talked about abuse and this change in the limbic system and the brain and the neurotransmitters. What are some other underlying factors that you see for those people with fibromyalgia?
Yeah, I'm happy to talk about that. I wanted to touch first on what you just said because I concur with that. I mean, in my medical training, I wasn't prepared right either. So when and before I went to medical school, I actually went to chiropractic school. So I became a chiropractor first and then a nutritionist, then a naturopathic medical doctor. So I kind of see it from the structural side, from the biochemical side, and kind of every way in between. So I think it gives me a perspective that gives me a bit of an advantage to have kind of tried to figure this out as much as I can. But in all of those levels of training, I still don't feel like I was ever prepared. So I learned really quickly I didn't have the tools to offer these patients what they needed. So I took it upon myself to go and dig and do systematic literature searches and kind of become an expert on it to the point where I was publishing, I was researching, I was writing textbooks, I was writing medical journal articles. And originally I was doing it to try to educate my colleagues, try to educate other doctors about this so that they're more prepared for it. And I think there was limited success there, but it's hard to the way people do things sometimes. So I tried to bring the story right to the people that have it with the book and the summit. And partly because I saw people coming in that I think were literally not only mismanaged, but in some ways almost abused by the system. A lot of these people already were abused, right? And they had some really bad stuff go on. And then they come into a medical system which kind of abuses them again. And let me explain that. It's much better now, but if you go back 10, 15, 20 years, especially if you go back 20 years or more, the majority of the doctors were male, okay? Luckily, it's changed now, but the majority of them were male. Most of the patients with fibromyalgia are females, right? So they would come in and they would get discounted by the male physician, told out, and they're thinking, oh, they're just hysterical. It's all in their mind. They're given psych meds, they're given, or given the brush off, sent to a psychiatrist, what have you. Some of these women themselves were kind of, their abusers were male, and now they're being sort of abused again. It's almost like a revisiting of it. It's terrible. So it's much better now. Now I don't think that doctors are that callous about it, but they don't just brush people off and tell them that it's all in their head. There's nothing really wrong with them. It happens some, but not a lot. They're just not prepared to deal with it. So they become the problem patients, right? They're the patients when a doctor looks at their schedule in the morning, they see Mary Jones with fibromyalgia and they go, oh no, she's coming in again, right? Because they just don't know what to do. So like you said, in the functional medicine model, we don't mind seeing those patients. We actually like it because if you really learn how to deal with these patients and you do the right kind of workups and you're not sort of confused, frustrated, and intimidated by the whole thing, they can become your favorite patients because it's not easy, it's not hard, I should say, for you to look like a hero, right? Because just by doing the right thing, right? So we look into those underlying causes, and first we're trying to find out, listen, do they really have classic fibromyalgia, or do they have other stuff that I need to dig and find out what it is and fix it? And in fibromyalgia, to make sure someone has classic fibromyalgia, we're just simply following the basic diagnostic criteria. Does the history line up? Do they have a history of trauma, abuse? Do they have a history of a lot of stress? Are they a classic sort of compulsive, I tend to explain these people as sort of, they're like Uber or Mega Mom, right? In personality. They're all about taking care of everybody around them. They're always worried that something bad's going to happen to someone around them. They need to kind of take care of everybody. They don't take care much of themselves. They take care of everybody around them. And they tend to be a little bit compulsive, like everything has to be neat, everything has to be in its place. They tend to be very high achievers. But often they're in a family environment where they're never able to live up to expectations, even though they're very high achievers, right? So it's, the more you see a lot of these patients, the more you kind of get what you're looking for in the history. And I don't mean that every single patient with true classic fibromyalgia clicks all those boxes, because they don't. But the more of them that they do, the more it makes sense. In the history, things like depression, anxiety, unrefreshed sleep, it almost needs to be there, some level of intestinal problem. So if they come in and they just say that they have a lot of pain, they're not fatigued, they don't have gut problems, they haven't had a lot of stress in their life, they don't have anxiety, I'm not thinking it's classic fibromyalgia. I'm off looking for other things. We have to do what any physician would do. We have to do some basic laboratory work and make sure all their organs are fine. They don't have cancer. They don't have MS. They don't have, overt hypothyroidism. They don't have some other hormonal issue. They're not anemic. They don't have respiratory disease. They don't have, heart failure. They don't have kidney failure. All of that stuff we have to rule out. And then once we do, we then tend to move into more of the stuff that doesn't pop up on the conventional doctor's radar screen. So I know you and I might look to do things like organic acid testing and see, how are their cells making energy? Are their mitochondria, these powerhouses of the cells, working right? Are they making enough ATP or energy for the person to feel like they have enough stamina to get through the day, so that they don't feel ickiness in their muscles, so that they can think straight? We look at their thyroid with a much more granular approach. We look at a lot more hormone fractions related to the thyroid and how the thyroid's performing out in the peripheral metabolism. So we're running down a lot of other things that the conventional doc is generally not doing. And when we do that, we often find problems in these different buckets, as I call them in the book. And instead of calling those fibromyalgia, instead of saying, oh, they have secondary fibromyalgia to mitochondrial disorder. No, they don't. They have mitochondrial disorder. Or they don't have fibromyalgia secondary to hypothyroidism. They have hypothyroidism. Find it, fix it, and see where they land, and then go from there.
So we talked about a lot of the overlying symptoms with hypothyroidism and how,
Right.
as you just mentioned, a lot of people can get diagnosed with fibromyalgia where actually they have an underlying thyroid disorder. They get on
Yes.
thyroid replacement hormone, their fibromyalgia goes away. But there are actually a lot of people with fibromyalgia that also have thyroid dysfunction,
Absolutely.
particularly hypothyroidism.
Absolutely. Yep.
Is there a connection there?
I cannot tell you that I know all of those connections. I don't
Right.
think anybody does. But the mere fact that the very, very large percentage of people that truly have fibromyalgia are women. And women have way, way, way more hypothyroidism than men. And there's
Thyroid
reasons we
disease
can...
in general.
In thyroid disease in general,
And
yes.
autoimmunity.
So when you stack that up, that it's the same patient population, okay, and then you lay on top of that the symptoms overlay very, very much, it's not uncommon that you're going to see patients who really have hypothyroidism being diagnosed with fibromyalgia, patients probably sometimes who have fibromyalgia being diagnosed instead as hypothyroid initially. And then those patients who, you can never forget the old adage that the patient has the right to more than one disorder at any given time, right? We tend to want to profile people into one kind of problem very reductionistically, and that's not a good thing to do. But I do think it's true that if you take fibromyalgia patients who really have classic fibromyalgia, those women who have classic fibromyalgia have even higher rates of hypothyroidism than women in general. So there is more of a connection there as well. And it might be due, I think it's due mainly to the fact that in classic fibromyalgia, there's a strong stress component, right? There's this history of stress. There's aberrant stress functionality in the brain, and there's aberrant levels of the stress hormones. These things are like cortisol, like epinephrine, norepinephrine, or the catecholamines. These hormones have influence over thyroid physiology, particularly thyroid physiology out in the peripheral tissues. After the hormones leave the thyroid, there's a conversion process to active hormone, and that can actually be sabotaged by stress hormones. So there's a lot of complicated reasons why these disorders often coexist, and they certainly do.
Right. But in case someone's only joining for your particular talk, why don't you talk about why many people come in and they say, well, my thyroid, my doctor already checked my thyroid, told me that it wasn't my thyroid, and I do definitely have fibromyalgia. So how are those people getting missed with their labs?
Yeah, it's kind of the same reason why people, even just with hypothyroidism, get missed a lot, whether they have fibromyalgia or not, in that even though the research contradicts this as being valid, what is in medical research is often very different than what is done in clinical medicine day in, day out in someone's practice. And oftentimes, the research is far ahead of clinical medicine, but oftentimes doctors are only looking at a couple of markers. They may just look at what's known as the TSH, thyroid stimulating hormone, to see if there's a thyroid problem, or maybe they look at one of the hormones, which we call thyroxine or T4, total T4. Those tests are generally enough to pick up if someone has really bad, what we call overt primary hypothyroidism. But there's so many people who have more subtle thyroid disorders that will not be picked up on that kind of screen. You have to look more deeply. You have to look at what we call the T4 and the T3 hormones, and we look at the total and the free versions of both of those hormones. So that's 4 markers: total T3, total T4, free T3, free T4, plus the TSH. We also look at antibodies to see if there's autoimmunity, and we look at something called reverse T3. So I'm sure other speakers are going to get into all the granularity there, but you have to look at it at that level if you really want to optimize someone's thyroid. And it's really important in these patients who have fibromyalgia, or anybody who has persistent fatigue, persistent achiness, and they were told by their family physician or even by an endocrinologist, your thyroid's fine. I think they really should see someone who's going to dive deeper into their thyroid function, because I've seen for over 20 years that if the symptoms line up, if they have all the symptoms of hypothyroidism, and you do those more granular labs, we see patterns where they're not converting these hormones very well. And we'll see, their T4 levels might be kind of hanging in there, but their T3 levels are really low, particularly free T3. Their TSH is well within the normal range. So if you're only using that marker as your guide, you're missing the boat. And if the lab pattern lines up, looking at it more, specifically, and the symptoms line up, and you do a trial of giving some thyroid support, either correcting reasons why the thyroid is being sabotaged. It could be correcting stress hormones. It could be lowering toxic load. We know things like mercury and transitional metals can really slam those enzymes that convert thyroid hormones, and other toxins can block thyroid hormone as well. Things from, residues from plastics, for instance, herbicides, pesticides. There's many things in our modern environment that are really ganging up to mess up thyroid function. And then we have autoimmunity against the thyroid, and we'll hopefully get into that with some gut connections, which is another connection between fibromyalgia and hypothyroidism. But if you really check it to that level and then give a patient a trial, even if necessary, of the right kind of thyroid hormone replacement with T4 and T3, oftentimes they literally feel like a new person. They feel like before they got hit by a train, and now they're back to being them. And in both cases, the standard labs that were done by their, let's say, family physician, they were normal in both cases. They were both within the normal limits. They're drastically different, but they're still within those wide ranges that are on lab work. In one case, they feel like they can't even get up and get through the day, and in the other case, they feel like a new person.
Right. So I think part of it is that either they could be within normal range but not optimal range, or that their doctor is not even checking the particular lab, for those conversions and whatnot. Are there any patterns that you see with fibromyalgia patients difficulty converting from T4 to T3, high reverse T3, or even autoimmunity?
All of the above, actually. The fibromyalgia patients, when we check their thyroid, often what you find is their TSH is well within that normal, 95th percentile, we call it. So they're not different than 95% of the population, which you have to be abnormal on those labs. But they tend to creep into the higher part of the TSH normal range. So they're 2.5 or above often. But when we look at their hormones in all these different, iterations, they definitely have problems. And what you often see is their T4 levels. Their total T4 is kind of the best of the bunch. It's kind of hanging in there, maybe in the middle part of the range. Their free T4 is in the lower 25th percentile. And then their T3, both total but particularly free, is usually way down at the bottom of the range. I see a lot of fibromyalgics where their free T3 is right on the rock bottom of the normal range. So it's down around 2.2, 2.3, something like that. And I see a lot that their total T3 is actually overtly low, but no one ever checked it. Their reverse T3 tends to be high. So if you do what's called the reverse T3 ratio, it's abnormal. And not all of them, certainly, but a significant number of them, if we do the various types of thyroid autoantibodies, show some level of autoimmunity against the thyroid. And then when we go back and check, well, why are they reacting against their thyroid? It often comes down to one or two or sometimes three different things. I've seen all three gang up on some patients, but we'll look at the gut ecology and we'll test all the different bugs that grow in the gut. And now with DNA or molecular technology, we can really do that in a much more precise way. And we can look for instance, certain bacteria that we know if they overgrow in the gut can stimulate the immune system and confuse it to react not only to that bug overgrowing in the gut, but also to the thyroid itself, and actually right to the TSH receptor on the thyroid. And there's a bacteria called Yersinia enterocolitica, which we look for and we frequently find. And if we find that, we want to try to eradicate that, because that is stimulating this response against the organism, and it has proteins on it that look a lot like the TSH receptor proteins in the thyroid. So you can kind of redirect your immune system to, instead of attacking that bacteria, also attack your thyroid. But that can also happen with chronic viruses, things like Epstein-Barr virus, cytomegalovirus, some of the herpes viruses. So various viruses that are sort of these ubiquitous viruses that once we get exposed to them, we never quite fully eradicate them. If our immune system is not in great shape and it allows them to flourish a little bit, they can cause what's called the bystander effect, where these viral entities can actually get into the thyroid, and when the immune system's trying to attack those viruses, it can actually inflame and degrade the thyroid tissue itself. And then the final aspect is them reacting to food proteins or food peptides. And there's a strong correlation, for instance, as you certainly know, between some of the fieldgrass grains and thyroid autoimmunity, particularly gluten and gliadin. Antigen antibody complexes have an affinity for the thyroid as well as the brain and the central nervous system. So all of that has to be run down, dealt with, and those sort of agitating factors sort of taken off the plate, if you will, sometimes literally off the plate, and to help the patient into their recovery.
And so how are you normally screening for these different bugs, and then how are you treating them?
Well, sort of the most common things that we do, after we do like normal lab work to rule out all the medical stuff, right? And we do the thyroid panels and things like that in a granular way to rule out thyroid disorders. We tend to, if we're if we get a thyroid autoantibody that's high, for instance, or just if we have someone who has profound fatigue and achiness and all these different things, and we don't have another reason for it, whether it's classic fibromyalgia or not, there's a couple of go-to things that we tend to rely on. One I mentioned before is an organic acid test, because that's going to tell us how are the cells performing in very critical aspects of biochemistry. How are the cells making energy? What is the status of various critical neurotransmitters to someone with those kind of symptoms, including someone with classic fibromyalgia? So we'll look at the neurotransmitters or neurotransmitter metabolites of critical brain chemicals like serotonin, like the catecholamines, the adrenalins, epinephrine, norepinephrine. We'll look at chemical evidence of overgrowth of the wrong kind of bacteria or fungi in the gut. We'll look at evidence that this unique individual may need more of a certain vitamin or mineral that makes certain key enzyme pathways run right, if they are under undue oxidative stress. So it tells us a lot about their personal biochemistry and gives us leverage points to kind of rejuvenate their metabolism. The other most common test we go to is to look at the GI microbiome in a very systematic way. And I use a test called the GI map, and it's a molecular or DNA-based analysis. And there's other tests out there as well that allow you to assess the GI microbiome. And we're looking for these bugs that can cause problems. And if they're there, we'll treat with probiotics, we'll treat with antimicrobials. Generally, we try to use antimicrobial botanicals and volatile oils and other types of things that'll nudge the gut ecology back into the right groove, if you will. Rarely we'll have to resort to prescriptive antibiotic agents. We use some locally acting ones whenever possible, but we really try to avoid those whenever possible. And then the other thing we'll look at is ways to test how your immune system reacts to foods that you eat. So not necessarily food allergy in its classic sense, so not the lips swelling up and the short of breath and all of that, but looking at which foods do not get along with your immune system and activate what we call the inflammasome. So if there are foods that are activating your immune response, it's sort of more load on your system. And there's various ways to test that. I tend to use a test called an ALCAT test that looks at what are the white blood cells doing when they're exposed to different foods. There's other types of labs out that kind of try to look at that same type of phenomena of activation of inflammatory pathways, or what we call the innate immune pathways from foods. And the ones that light up the person's immune system, we pull them out of their diet, at least for a while, and then over time we'll try to repair the gut lining, deal with any leaky gut, digestive issues, and then systematically over time slowly work foods back in to see which ones they can then tolerate again and which ones they can't. But often if they have thyroid disorder, particularly autoimmune thyroid disorder, usually we'll have an ongoing recommendation to them to stay away from the gluten containing grains.
Yeah, definitely. I recommend that all thyroid patients, particularly those with autoimmunity, don't even bother to add back in gluten, and typically dairy as well, because of the casein with the molecular mimicry.
I agree. Yeah, absolutely.
To gluten and then to the thyroid.
Yeah.
And have you read a fairly recent study about 50% of those with Hashimoto's also have SIBO, small bowel bacterial overgrowth?
Yes. What's interesting also, this overlay again, these
Probably
connections, is I wrote a whole chapter in a book called Integrative Gastroenterology, which came out of Johns Hopkins Medical School with a friend of ours, Jerry Mullen, was the editor. But I wrote the chapters specifically on the connections between fibromyalgia and irritable bowel syndrome, but also fibromyalgia and SIBO, or small intestinal bacterial overgrowth. And when you look at the epidemiology, almost 100% of people who truly have classic fibromyalgia have IBS, and pretty similar number have some level of small intestinal bacterial overgrowth. And there's even some models now being suggested in fibromyalgia that at least some patients who have true global tenderness, they do have achiness all over, and they have mood disorders. They have a lot of the things that you would come to the conclusion that they have classic fibromyalgia, that they actually have dysbiosis or overgrowth of certain bacteria in the gut particularly SIBO, which is overgrowth of bacteria in the upper GI area that can cause a lot of bloating, particularly after meals, particularly after carbohydrates, a lot of distension, a lot of discomfort, that these bacteria that are overgrowing can produce certain metabolic toxins. They can express certain peptides. They can express certain lipopolysaccharides that actually can interact with the immune system and through what's called the gut-brain connection. And there's even theories how it's transmitted through vagal nerve innervation. And I won't go that deep in the weeds, but that it can actually, these compounds, these chemicals can get into the brain. They can pass what we call the blood-brain barrier and actually activate the immune system within the brain. And when we trained in medical training, the brain wasn't even supposed to have an immune response,
Right.
but it does. It's called the microglia. And the microglia are activated in a lot of patients with global pain. And this activation can actually be a downstream manifestation of problems in the gut. So it's really fascinating stuff. So this deep brain inflammation may be causing deep-seated brain pain, which can be interpreted as fibromyalgia. Now, I will say there are some people jumping on the bandwagon saying, oh, this is the cause for fibromyalgia. And the jury's out, right?
Right.
But
There are
I can
probably
tell.
plenty of people that you've solved their SIBO and they still have fibromyalgia, and then a whole group of people that you've solved their SIBO and their fibromyalgia went away.
Well, that's the point, right? We all want to
Right.
find the universal cause of everything. But in a lot of these chronic disorders, fibromyalgia not being an exception, there are multiple avenues in probably to get to that same constellation of symptoms. And the whole model of bacterial overgrowth and their byproducts activating the microglia, inflaming the brain, and causing fibromyalgia does not explain some critical observations. And therefore, the giants in fibromyalgia research do not think that that's the universal or a unifying cause of fibromyalgia, because it doesn't explain why women are affected extremely at higher levels than men, right? Like
right, there's probably some
90+%
hormonal component as well. And that's, I tell people when somebody comes in with rheumatoid arthritis, there's sort of 5 key factors that I'm thinking about with everybody with any sort of chronic condition, which is food sensitivities, gut dysfunction, toxins, stress, and infections. And for one person with rheumatoid arthritis, they might have 2 out of the 5 of those. With somebody else, they might have 5 out of the 5. Or somebody else, it might just be gluten, and they get rid of the gluten.
Exactly.
So
it's the same thing. It's no different
thing here.
No different in thyroid disease, no different in fibromyalgia. But the other thing that model doesn't explain is why you occasionally get people who really do have global pain, global fatigue, unrefreshed sleep, all of that, and they don't have gut problems. I mean, you test them every which way. Their GI microbiota looks good. Their breath tests are negative. They don't have symptoms of SIBO. They don't have a lot of gut issues. Now, it's true that most do, but some don't. So
Right.
the model doesn't hold true there. And there are some other, I won't get too deep into it, but those microbial inflame the brain models don't explain every aspect, and we just may not understand how they connect. But the unrefreshed sleep, the alpha wave intrusion and delta wave sleep, all those things, there may be a relationship, but it just hasn't been established yet. But it is very interesting, and we're following it as it emerges, and it's another factor that we have to consider when we're dealing with these types of patients.
Right. So it sounds like fibromyalgia can get misdiagnosed, or hypothyroidism can get misdiagnosed as fibromyalgia. Those
Yes.
with fibromyalgia can have hypothyroidism or thyroid dysfunction to some degree.
Absolutely.
And then there are a whole host of triggers for both thyroid dysfunction as well as fibromyalgia. And we kind of talked through some of those being, toxins, infections. Any others that you want to, foods, obviously, stress.
Well, I'll go back to the stress, the personality type, the constitution, if you will, of these patients generally, and the commonality in their previous history. It doesn't always have to be abuse, like everyone thinks, sexual abuse, physical abuse of the person. It could be abuse of their mom while they were growing up and they watched it. It could be just sort of oftentimes it's a very authoritarian, sort of often substance abuse kind of dad in the household, right? Sort of the angry yelling, kind of father figure is very common, but it's not always that. Sometimes it's a car accident. Sometimes it's witnessing some horrific thing happening to someone else just by chance, right? We know that the later that the trauma, the stress, or the event happens in life, the less likely they are to go on to develop something like classic fibromyalgia or IBS. The earlier they witness it or suffer it or experience it, the more likely. So it tends to make us think that the more immature and neuroplastic we are, or the more the nervous system is still learning and figuring out the world, the more it's in that state when something happens, the more it's susceptible to aberrant function later. Where if you're already an adult and patterns are set, and you have that kind of experience, unfortunately, it's not to say that you can't go on to develop those kind of things, but it's not nearly as common. So when we have someone who has classic fibromyalgia, in the functional medicine model, and I go into this in depth in the FibroFix book and on the summit, we don't just reflexively use the drugs approved for fibromyalgia, right? Which are really retread drugs, right? They're just reissued drugs with a new purpose and a new approval. So the 3 approved drugs right now, 2 of them are SNRIs, selective serotonin norepinephrine reuptake inhibitors, which are recycled antidepressants. The other one is an alpha-2 delta ligand anti-epileptic drug. It was originally developed for seizures, okay? The drug that they used prior to those approvals off-label was another class of antidepressant, which is known as a tricyclic antidepressant. So none of these drugs were really developed from the ground up to treat fibromyalgia. They just happen to be drugs that physicians often tried off-label out of desperation, and they seem to afford some people help. Some of the people they helped were because they really had other problems that the drug treats,
right,
and not fibromyalgia. Some of them helped, like for instance, the amitriptyline for many decades was the go-to drug for fibromyalgia, a tricyclic antidepressant. And people think it was used originally with fibromyalgics because they also tend to be depressed. It really wasn't. It was used by sleep specialists who figured out they had sleep dysfunction. And it was used to drive them into deeper, more refreshing sleep. And then they figured out, hey, it did help them sleep, and now they have lower pain scores. And, they have better functionality. Same thing with things like SNRIs, newer class of antidepressants. And the anti-epileptic medications just dumb down the whole brain. The central nervous system is just dulled. So the patient is dulled, right? So they often feel like they're walking around in a zombie-like trance, So they don't like them, and a lot of people discontinue those medications because of the side effects. And unfortunately, the data on those medications is that of people who actually are accurately diagnosed with classic fibromyalgia, and it's a hurdle just to get there, right? But once they're accurately diagnosed, if they try one of the 3 approved medications for fibromyalgia, the latest large study shows, and this was a conducted trial, it was very well done, about 22% get significant benefit. And of those, most of them have diminishing returns over the course of 3 to 6 months. So 6 months out, the large majority of them, and this is only 22% to begin with that had a good result, the majority of those are down, they're back at where they started, and all they have added is the side effects from the medication. So what I'm saying is I use some of those medications at times in the right patients with classic fibromyalgia to see if they're a responder or not, and to see if it might help them and ease their suffering and their symptoms. But I certainly don't look to the pharmaceutical world as there being any cure or panacea or something that is tremendously effective. We use that when we can, when it's appropriate. We'll use other drugs off-label to help with sleep, because you got to get them sleeping. You got to get them into deeper layers of sleep. We'll use things like low-dose naltrexone to deal with that microglial inflammation in the brain, because they're pleomorphic agents, or they work in these really strange micro anti-inflammatories. Oddly enough, even opioid pain medications don't work with fibromyalgia pain.
Well, let me ask you this, since in functional medicine we're really, getting to the root cause, and if you're finding that in many of these women, I'm going to say they're women since it's mostly women, the root cause really is trauma, heightened sort of vigilance, anxiety, this whole, mind-body type component, and particularly the trauma. What are you using in your practice, or what are you referring out to people? Neurofeedback. I mean, I spent a whole chapter actually in this book talking about, things that can help people. So what are some things that you're doing and that you found? Because I'm sure there are people out there listening and they're not getting offered this, right? They're getting offered the antidepressant, but we really want to get to the root of that trauma and help unstick them.
Well, the classic medical literature, I don't mean like the alternative medical literature, the functional medicine, I mean like nuts and bolts, major index journal stuff is very clear. The drugs don't work that good. That's what those journals say. But the things that do, that have strong evidence base, are improving sleep, right? Cognitive behavioral therapy. And under that umbrella comes a lot of different possible things. Something as simple as progressive relaxation, deep breathing exercises, guided imagery, meditation, yoga, tai chi, qigong, all of these practices that are sort of soothing, that lower the stress meter, that are sort of centering, you're spending some time on yourself and you're undoing the stressors of life, particularly Western life, that, the stressors never stop. We pay a lot of attention to sleep hygiene. We'll get people off screens later in the night, no devices, no iPads, things like that. We'll use software on their iPads or screens if they won't get off them that actually pulls the blue light out of their screens as the clock goes later into the day. Can be very effective. We have them do some of these cognitive behavioral at-home techniques in the evening when they're preparing for bed. We can use neurotransmitter nudges to get them to sleep better. So we use things like sustained release melatonin. We'll use 5-hydroxytryptophan that gets serotonin levels up throughout the day, but particularly in the evening. It'll lower their perception of pain. It'll increase their mood. It'll help get them to sleep, get them into deeper stages of sleep. We'll use calming, stress relieving, adaptogenic botanicals. So things that are good for the adrenal gland and stress. So we'll use things like Withania somnifera or ashwagandha. We'll use German chamomile. We'll use agents like pharmaceuticals. So we'll use actually the neurotransmitter GABA. We'll use L-theanine, phosphatidylserine. There's all kinds of things in the nutritional, botanical medicine, functional medicine practitioner's tool bag that calm the nervous system. We'll throw them all at somebody and we'll try to figure out which work the best.
I've pretty much tried everything you mentioned there.
We have to get them moving again though too, and a lot of times these patients are afraid of movement and exercise because when they try to do it without doing it the right way, they can really crash and burn and then they're in bed for 3 days, right?
Yeah.
So
what about infrared sauna? I find that can be helpful for a lot of people with pain disorders.
Saunas, infrared saunas, contrast therapy, saunas and then cold saunas, doing that kind of thing. And you have to be a little careful with that until the person's like prepared for it. But
have you tried float tank at all? The isolation tanks?
I have not tried it personally. I'm a little bit claustrophobic in that small of a space, so I have my own little phobias about it. I've not tried it with patients.
Okay, well, I'm super claustrophobic too. So anybody else out there listening that's claustrophobic, at least the ones that they have here, it's like a big pod and the top lifts. So you could get in it with the top open and just turn out all lights in the room. Or they have a little light inside and you can close it. I mean, what I do is leave a space this much so that I can still see out.
Right.
So
that would be okay.
Yeah.
As long as I know someone's not going to come along and lock it, not know I'm in it or so. Your mind goes crazy.
It's so funny to hear you say that because I'm the same way. I'll tell you a story when we're done about my first experience. But anyway, it's for those that are claustrophobic. I'm super claustrophobic, and there's ways to get around that. And I avoided doing it. Somebody told me to do it 2 years ago, and I didn't go.
There's no doubt that would be helpful, right? Because it's a centering.
So just so people don't know, it's considered, they call it an isolation tank because you're supposed to be devoid of noise, light, sound, everything, and you're floating in a big bath full of Epsom salt that is like 300 pounds, so you float. And so that, as opposed to infrared sauna, I mean, it's really relaxing and it's getting all those muscles to relax. I mean, trust me, I have tried everything. The cryotherapy, the sauna, the float tank. The float tank is really, I love my sauna, but the float tank is really, for me, they put so much chlorine in a lot of them that I have a problem with that. So I'd love one day to be able to afford to own one in my home, but
What we do have in our practice, though, is we have multiple hyperbaric oxygen chambers, and the real deal ones, the glass ones, the really high quality ones. And for patients that have classic fibromyalgia, particularly if they also have some concomitant mitochondrial energy production issues, if we can supersaturate them with oxygen and perfuse their tissues to a much higher level, I do find that many of them do feel almost immediate benefit and more energy. But the other thing we bring into it, and I need to use a team, right? So I have a practice partner who does a lot of brain mapping and real-time biofeedback and EEG work to train people how to get into calmer brainwave states on their own eventually. We use some of the new technology that you can put right on your laptop and put a sensor on your finger and train yourself to do heart rate variability based biofeedback.
You can get the HeartMath app on your phone now. So
Yes, exactly.
I was doing it this morning. So it's amazing what you can get just on your phone now without much, at a very inexpensive price. I have a heart rate variability monitor that I get up and check my morning readiness every morning, and I just strap it on, and then it was like $50, and then you put there's an free app on my phone, and it tells you all kinds of stuff.
Yeah, these biohacking devices now, some of them get silly almost, but some of them are amazingly.
Yeah, this one is great. Yeah.
The other thing though is oftentimes, particularly with those people who really had significant trauma and really adverse life events, they need some level of counseling if they haven't had it, or a different kind of counseling, because the old model of counseling, sort of, the Freudian model, if you will, is that you have to go back and relive it, process it, and get beyond it. And sometimes I think with these patients, going and reliving it is not the thing to do. It's stressing them again. So the new movement is more in having the therapist work with these patients with their relaxation, cognitive behavioral therapy kind of practices, but also the new wave is actually doing something called forgiveness therapy. And it's not about excusing, let's say you were abused by a family member, okay? It's not about excusing that behavior, but it's about coming to terms with it within yourself that you can't change the past. You have to acknowledge it. You don't want to dwell on it, but you have to acknowledge it. You have to accept it. And you have to move on some way, almost on a subconscious level neurologically. You have to let your nervous system move on. And some of the therapists use a forgiveness therapy. Many times, let's say the abuser now is old, a lot older, they're elderly often. You come to terms with the acknowledgement that they were themselves abused and they're sort of a repeat offender. They're not the same person they were then. Often, in the case of sort of that raging authoritative father figure, they're calmer now. They're not the same. Sometimes the person needs to work with a therapist to actually come to some resolution with that person. And sometimes that person's ready to basically apologize, say they're sorry, to acknowledge it. Sometimes they're not. Sometimes that person hasn't changed a bit,
Yeah, are you familiar with Peter Levine's work, Waking the Tiger, the somatic experience, and then there's EMDR and tapping? I think there are also, if that isn't appealing to somebody to actually engage with their, abuser and forgive them, there are other ways to sort of get this out of your nervous system as well.
There is. And I want to stress the forgiveness therapy. It's not about excusing what happened.
Oh, of course.
It's about sort of coming to terms with it. And there's a great level of self-resolution, and it's beneficial to the person who may have been the abused, especially if it's a parent. All right. If that parent dies and there was never any resolution, and that's what's left on the table, it's very, very damaging. If there's an opportunity to somehow come to some better ending, if you will, it actually is very therapeutic for that person.
Before we part, can you give us, I always like to have people have 3 takeaway points that maybe they can start, today, helping them with their fibromyalgia. Anything that you can think of, 3 kind of takeaways or 3 things they can do on their own at home?
Well, the first thing is to come to absolute certainty that you can recover. A lot of people with fibromyalgia have been disappointed. They've been to a lot of healthcare practitioners, didn't really understand it. They've been dismissed. So they've sort of gotten into the mentality of, I have a chronic illness, I'm never going to get better. This is who I am. This is what I am. I'm a burden to everybody. get over that, find someone who can be your advocate along with yourself, as getting educated as your own advocate, and first of all, acknowledge you can recover. Second of all, find someone who can help you recover. Find a good functional medicine physician, a good functional medicine nutritionist, a health coach, somebody who understands this, okay? And then start slow, and then go through some of the basics. My book is a good place to turn. The Summit's a good place to turn. It'll bring you through action steps that you can drive at home. You don't even have to be dependent on someone else, but you need to do them in a certain sequence and in a certain level of sort of a vigor, if you will, and not go too fast. And you can start the road to recovery with cleaning up your diet, getting less inflammatory, rejuvenating your metabolism, starting to move again and regaining functionality and movement and range of motion, and then starting to integrate some sort of stress reduction, cognitive behavioral practice into your life. Just those things alone can make remarkable differences. And then if you can find a good functional medicine physician that can really dig deeper into the weeds and balancing your neurotransmitters, your stress response, optimizing your mitochondrial function, that stuff's even a benefit. That's going to take you to the next level, and that'll get you to that place of full recovery, which I hope that you achieve.
Awesome. Well, thank you so much. And why don't you tell our listeners how they can get in touch with you, where they can find you, and your book?
Yeah, thank you. My clinical practice is at Whole Body Medicine in Fairfield, Connecticut. I spend most of my time at the University of Bridgeport here, where I'm coming to you from now in Connecticut, in my academic life. But they can learn more about me in general at my main website, drdavidbrady.com, just drdavidbrady.com. But if they want to learn more specifically about fibromyalgia, the two real go-to places are the website for the book and the community built around fibromyalgia, which is fibrofix.com. So fibrofix.com. And then if you want to go and participate in the summit, it's still active. You can go and benefit from over 35 experts around the world talking about fibromyalgia and all the things associated with it, and real practical action steps to recover. That's just fibrofixsummit.com. So please come join my community at fibrofix.com, get my newsletter, look at the blog, chat with people, find people who are in the same situation who have recovered, and get a bunch of really good educational resources that are free for anybody.
Great. Thank you so much, David.
You're welcome. Thanks for having me. I wouldn't dream of missing it, so thanks.
Awesome. Take care. Thank you.
Okay.
Bye.